Good evening, everyone. Here Imran Abbas from Dubai. Again, we are live from Dubai and Professor Safwan from Abu Dhabi. It is great honor for me to interview such a great personality and expert of bariatric surgery, especially sleeve gastrectomy. Professor is a big name in bariatric surgery world, and he's a well-known person, well-known personality. He has lot of services, especially for promoting general surgery, laparoscopic surgery, and also especially bariatric surgery. He has a lot of contribution in American College of Surgeons and long time president of chapter of UAE, also governor of chapter of UAE, especially for American College of Surgeons. It is really, I feel, a great honor to interview such a prestigious figure. My viewers, this is great opportunity for all of you, especially for me, to learn about safe sleeve gastrectomy. As you know, we have started this series of safe sleeve gastrectomy since July 2021. We will continue this series till December 2021, and in December 2021, we will have sum up session. So this interview series is little different than a webinar, because in webinar we have such a legends, but unfortunately due to shortage of time, so we have no this opportunity. So more questions and talk. So in this interview, yes, this is in light mood. You can ask any question. We are live on our Facebook group, Global Laparoscopy. You can ask any question and Professor will share his own experience. This is great honor, sir. Really great honor. I know you are so much busy for your time. Professor, over to you.
Imran, thanks a lot really for this great opportunity. Giving me the chance to share my experience with the prestigious audience. I've been following the series very closely, and I'm very much impressed with the quality and content and the level of this guest that you have chosen. It's really a big thing that you're doing, and I'm one of the people who appreciate it a lot, adding this much of information and international expertise to the international literature. Thank you very much for the honor of hosting me in this series. Thank you.
Sir, your greatness, really, it is great honor for mine and our group, this GLR group and our team. Sir, as you know, we have because repeated questions, because at the end, what is our target? Because in December, so definite, we will repeat these questions, and at that time, so we will ask these same, we'll share these videos, and this is our target. So, sir, because I know personally very well yourself, and many of us we know, but this is the part of our question. Sir, your brief introduction.
Thank you very much. My name is Safwan Taha al-Ma'tuq. I'm consultant bariatric and metabolic surgeon in Mediclinic Hospital Airport Road in Abu Dhabi. I I'm a fellow of the Royal College of Surgeons and Physicians and Surgeons of Glasgow. I'm fellow of the Royal College of the American College of Surgeons. I'm Arab board certified general surgeon, and I hold a diploma of laparoscopic surgery from Strasbourg. I've been doing bariatric surgery for 12 years now. And I'm also currently, thanks for touching on that, I'm currently the governor of the UAE chapter of the American College of Surgeons.
MashaAllah, MashaAllah, sir, it's a great honor. Sir, regarding your, yes, you have mentioned, so you are more than 1 decade, you are performing bariatric surgery, but we are interested to hear more about your bariatric surgery, this journey of this bariatric surgery, when and which type of bariatric surgery you have started, and nowadays your experience.
Yeah, I started. My real start was 2009, and initially it was gastric bands and sleeves. Bands were really like 20% of our practice then, and sleeves, and then gradually it progressed to what we're doing now. Now we're a center of excellence in metabolic and bariatric surgery, accredited by SRC. I'm also a master surgeon in metabolic and bariatric surgery by the SRC, just like yourself. And currently, I'm doing like 45% sleeves, 30% revisions, 20% OAGBs, and 5% Roux-en-Y gastric bypasses.
Sir, excellent, sir. So definite now you are performing and doing this sleeve gastrectomy or bariatric surgery more than 1 decade. So one question, because definite, when we start, I remember also I start with gastric bending and progressively. So we shift our practice from gastric band, sleeve, Roux-en-Y, and different types of bariatric surgery. But during this journey, definite, every surgeon evaluate himself and change his practice. These tips and tricks are some points for better results. Sir, we are interested, our viewers are interested to know that points, that tips and tricks so far better results. Like, because at the end we will discuss also about GERD after surgery, weight regain after surgery, and also leak, bleeding. So definitely this is a part of our practice. So which points if you want to highlight, as you have changed during this journey of sleeve gastrectomy?
Absolutely. I mean, there are quite a few subtle changes that probably are of secondary importance, but the major changes over the years that I would consider, and I believe most sleeve surgeons now acknowledge it, are mostly the following. Firstly, when we started doing sleeves, we were going like flush with the esophagus at the GE junction, and of course not anymore. Now we go like half a centimeter to probably less than a centimeter, giving some space there for to improve the vascularity of the area and decrease the chances of leak at the commonest part. Secondly, which is really also important, is the incisura. I mean, there's a firm belief now that it's tighter than should be. Incisura is a major contributor to reflux and even leak. And the third thing I changed, I mean, I started doing 6 centimeters from the pylorus and then shifted to 4 centimeters from the pylorus. And I would say the last important change is that when I started, I was still doing it on a 36 French bougie. But when I started, I was going very flush with the bougie, tight with the bougie. Not anymore. I mean, over the past 6 years, I'm going close to the bougie, but not too close. It's not too tight. It's just touching the bougie, as I'll show you in a very short video later.
Sir, please, we are interested to see your video or any slides.
So, I mean, you'd like me to show me the video now?
Yeah.
Yeah, okay, sure. Can I share the screen?
Oh, sir, you can share.
So, I do, I mean, the other thing that I changed, that's not related to the technique of the sleeve, that's me. I'm doing routinely now 3-port bariatric surgery, whether sleeve or OAGB or even revisions. The only exception is the Roux-en-Y gastric bypass, and I use the crural stitch to as a liver retractor, as you can see here. So the basic things in the technique, but that's the stomach, and I do 4 centimeters from the pylorus, but I've been doing that for 13 years now, but I don't want to depend on my estimation. I put a tape measure.
Sir, I am interrupting. Sir, I am interrupting. Is it possible to show us that stitch for liver retraction?
Absolutely. I thought probably the time.
Yeah, thank you. Thank you,
okay. So this is it's a straight needle. Okay, I'm just checking the abdomen when I went in and checking the anatomy in the beginning, and that's the crust, as you can see here.
Yeah.
I show it to you now. I push the needle at the epigastrium, a straight needle with proline.
Excellent.
All right, and then I will go through the stitch, the crura, as you can see here.
Yes, sir.
And I go through the crus, the upper extension of the crus, and then I go to the right hypochondrium and take the needle out there. My nurse will just, as you can see here, it's a straightforward process. It's not really a difficult thing for a fairly trained laparoscopic surgeon. And I push it through the anti-abdominal wall. Just make sure not to go very close to the rib, because the new vascular bundle is just below the rib, and you might get bleeding that might be a bit annoying to control. So just give it an inch or so. And then the nurse will pull it up, and you just tidy it, the angle here, and here you are. It's a perfect retractor, a very nice retractor, and I use it for, routinely. It works in like 96%, 97% of cases.
Excellent.
So I use the tape measure just to make sure that it's 4 centimeters, because if you go closer, you don't want to go, to like 2 centimeters to the pylorus. So there's so many controversies about that. Some people do it, but there's evidence in the literature that if you go 2 centimeters or closer, you might get a higher incidence of leak, because even the highest staple heights will not be able to accommodate the very thick pyloric muscle, and it might not show intraoperatively, but it will show later. So I make sure that I don't go closer than 4 centimeters. I put a little mark, and then I start the section. I start the section a bit not high, like 1/3 of the body of the stomach, because if you go down here, it's much thicker, and it will take you more time to go through the gastrocolic omentum. You can use the energy device that you like. It depends on the surgeon's preference. This is what I use, and I'll just expedite it a little. There's nothing special here. I just passed the my cautery mark with one inch beyond it, and then I proceed. You can start upwards first and then downwards. It's up to you. This is my preference. And sometimes, not in this case, sometimes when you find difficulty here with 3-port, if you want to continue with 3-port, I ask the anesthetist to push the tube, and I just like make it, I make him push it against the body, and then it will arch and act as a retractor. But I didn't need it here. As you can see, it's all done under vision, traction and counter traction, and every single step is done under complete vision. So there's nothing special. I'm just showing you how to make this section. The important part here is that you have to show the left crus. As you can see here, this is the left crus. You can see it very clearly here. And those are the 2 important things you should do. You should show the left crus, and you should chop off this pad of fat. I'm going back a little just to show this pad of fat. Those are 2 important things in steps in the section. The pad of fat should be chopped off, and the left crus should be very clearly shown. The other dissected. The other thing is that you don't need to over dissect the hiatus. There's a lot of growing evidence that over dissection of the hiatus is a contributing factor to the development of hiatal hernia that was not originally there. So the other trick that I forgot to mention, the other 2 tricks that I forgot to mention during the evolution of my technique are the following. The first one is I try as much as I can to push the tube into the duodenum and make it as a splint to the gastric body, so that I will start this section over the tube, which leads us to the second modification that I actually implemented like very early in my practice, like 1 year after I started doing that. And as you can see, I'm calibrating even the first bite. The first bite is, of course, the highest staple height. In my case, I'm using this type of staplers, so it's the black. And even with the first stapler, I'm calibrating against the tube. As you can see here, the tube is there inside the duodenum. So those are the other two tricks that are added to my technique. And of course, as you can see here, it's close to the tube, but it's not tight. And as you can see now, the next step that I always do is before firing is to move the tube up and down to make sure that it's not too tight. I have not taken the tube. As you can see now, the tube is coming up and down very freely without any issue. It's moving up and down, so it's fine. Now it's not too tight. I'm sorry, in this editing version, I didn't show the back. I always go to the back of the stomach and inspect the back and make sure that the staple, the cartridge is put in an even space between comparing the front and the back. So after I check the patency and it's not too tight, then I fire. The other technique also that I was sparing for later, but since you made me show the video, the manufacturers recommend that we keep the pressure before firing for 20 seconds. I keep it for 1 minute. And in my hands, I found that there's a big difference. And as you can see, by the time we finish here, sleeves this way, the way I'm doing it is literally bloodless. Most of the cases by far. I might need a touch of cautery or a clip every now and then, but by far most sleeves are dry because of those few modifications. And the last one of them is before firing, I keep it closed for 1 minute and not for 20 seconds. And as you can see here, the staple line is literally dry.
Yeah, excellent.
Yeah. Yeah, and that will go on for the entire surgery and for the vast majority of sleeves by far. And then, of course, you see, I use 3 ports, so only 2 hands. This is my left hand, and this is my right hand. I'll show you the configuration of my ports when I finish the procedure. And so, again, the same technique. I'll just apply the stapler, not too tight, not too light, and make sure that the tube moves freely, as you can see, it's very freely and unobstructed. And then I fire. Make sure that try your best to make your staple at the middle of the body so the anterior and posterior walls are equal. And I believe one of the best ways of doing that, besides comparing visually, is to put them at this level, at the end of the vessels, the gastric vessels, just at the tip, which should give you more or less a very uniform staple line. Again, it's the same thing. Give it 1 minute, move the tube, apply it, not too tight, not too light, move the tube, give it 1 minute and fire. And as you can see, it's always that the staple line is dry. So you go on with the same thing again, and it's very important. I didn't get it here. I always look at this area and look for the migrating crotch. Here, many times you'll find a loose staple, metal staple that you need to remove. I've never seen it after the first bite. Whenever I see it, it's after the first bite, commonly in the 3rd or the 4th. And you have to remove it before applying your stapler because it will obstruct the knife, and instead of the knife cutting this tissue, it will be this loose crotch cutting the tissue with a jagged, ugly wound. So it's better. I do inspect for it routinely every time. It's not here, thank God. It's not always there, but many times it's there. As you can see, the staple line is uniform, it's straight, it's fine. Now you apply the stapler. The other trick here that you need to do, I do, is making sure that the fundus is totally away from the stapler. And one trick of doing it, as you see here, I'm not going here this is too tight, but this is intentional. I'm not going to fire, as you see now. I go a bit medial when I introduce the stapler, just to make sure I'm incorporating the entire fundus with this bite. Otherwise, you might end up with a crumpled tissue here. So initially I'll go here medial, but then you'll see I'll just organize it and I'll open it now and go a bit lateral to make it really wide enough. And you can see here no fundus, and this is now wide enough not to cause any problems. And of course, I don't depend on my vision. The tube will always prove that it's easy. It's not only the way I see it easy. I asked the anesthetist, how does they feel it? And now we are working, and it's the same team for like 12 years. So they have this tactile feeling of the tube, whether it's smoothly sliding in and out or not. So this is the third stapler. As you can see, I started 4 centimeters from the pylorus, and it's a banana-shaped sleeve, not a vertical sleeve, but it's still four staplers are generally enough because of the nature of application of the staplers. Again, looking at the crotch, there is no migrating crotch here, and this is going to be the last firing. This is the 4th, and actually it's even a 45 would have done here, but I always like to be comfortable and make sure that this is important also. Sorry, let me go there. This is important also when you go here. I fired, I'm sorry. It's important that you see the other end of the stapler. If you can, if it's not the last one, of course you can't. But when you're fashioning the last staple, you look there and you see the other end of the stapler. You can see it there clearly.
Yeah.
It's very, very comfortable there. So again, you close it. And of course, a reminder for the juniors, the closure should be, the safe closure should be either in line or vertical. You don't want to go at different angles. And now, I'm sorry, and now after I applied it, now I see it's going to be vertical in line with the staple line. And now he is moving the tube, and the tube is going, I go to the chest now, and then enter again with the last firing. And once we're convinced, myself and the anesthetist, that everything is fine, then that's it. I'll fire the last cartridge. That's the 4th. And as you can see, it's a dry, uniform, straight staple line. And one other trick before I leave, I never leave the abdomen with blood pressure less than 110. For hypertensive patients, I go for 120 generally, or 115. This is the methylene blue test, not that it is, of significance when it is negative, but I do it routinely for all of things. As you can see, you love this technique because, as you can see now, when you apply suction, it's only water. There is not a single drop of blood in the procedure. It's literally saline.
Sir, excellent, really excellent.
Yeah. And the other thing, as I told you, now I will not go out. I will wait for a few minutes. I'll ask the anesthetist to make sure that the blood pressure is 110 or higher before I close. And I'm telling how now to take the tube out and to take the methylene blue out from the stomach under vision. I remove, I'll check the staple line again. I remove my retractor, which is the crural stitch, the proline crural stitch. And I wait like for 5 minutes until blood pressure goes for 110 or higher. And if everything is well, and generally speaking, by far, everything is fine, we leave. And of course, we'll take the stomach. Again, now the blood pressure is 115, something like that. So I went back and checked, and everything is fine. It's dry. There's absolutely nothing to worry about. The staple line is dry, and everything is good. Now I just take this remnant stomach I'll show you the wounds now and comment on it, and close the 15 millimeter opening with with endo close. I'll show you the wounds if you allow me.
Yeah, sure, please, sir.
Yeah, so this is the configuration of the wounds. Can you see it?
Not yet, sir. Please.
I'll have to share. Yes, just a minute. Share screen. Can you see it now?
Yeah, we can see.
So this is a 3mm port. I mean 3mm, 3-port approach, 2 5mm and 115, which is at the above edge of the umbilicus. And I put the camera here. Of course, I use a 5mm camera. And in the beginning, and do everything. And then when I go to the stapling, this will be the stapler. This will be my left hand, and that will be the the camera. This is the 5mm camera. And of course, I can show you the other the other where that shows the retractor.
Sure.
Sorry, it will show the retractor. Just a minute. I'm sorry. So let me share the screen. Sorry for the delays.
No, sir. No, we are just. It is.
So this is those are the retractor. You can see that. That's another 15mm, 5mm, 5mm, and this is the entrance of the needle, and that's the exit. And this is how you get the retractor. And after you finish the procedure, that's how will the wounds show. That's on table before doing. I mean, you know, later with the edema going, I'll show it to you now. So those are the wounds. This is the umbilical wound.
Excellent.
And that's the 3mm, and that's the 3mm. That's on the table. When they come on the 8th post-op day, you can hardly see them because edema is over, and they are hardly noticeable.
Sir, excellent, really excellent. And I can ask, so I can name this surgery scarless sleeve gastrectomy.
More or less it is actually. I mean, patients are very happy with it. Yeah, and I haven't had any problem with doing it. Of course, the important message I'm sending to all probably people who are starting the procedure is that even after 2,500 sleeves, when I get any difficulty in seeing or managing, I put a 4th port or even a 5th port, all 5mm, because safety comes first. But honestly, it's like 97, 98, 98% of cases of sleeves, OAGBs, and revision of sleeves to OAGBs, we managed to do them through 3 ports.
Sir, really amazing, and you demonstrate very, very well and definite there. So there is no question now, because technically and also tips and tricks, everything you demonstrate in this video. So much thanks, sir. We will go ahead and we will continue our interview. So another question that is also one of the most important question and related to patient selection. What is your absolute and so this relative contraindication of sleeve gastrectomy?
Well, the only absolute contraindication for sleeve gastrectomy is grade 3 and 4 reflux, diagnosed endoscopically or with other modalities, proven serious reflux. Grade 2 is questionable. Grade 1, we'll talk about probably later. I don't see a problem with sleeves with grade 1. But the real contraindication absolutely is grade 3, grade 4 reflux. The relative contraindications, I think, thank you for labeling this question as criteria of selection, because this is really important. Now, probably a lot of people are, including yourself, are noticing that we're getting now a lot of revisions of sleeves because patients who needed bypasses were offered sleeves for a lot of reasons. So the relative contraindications are the criteria, BMI, comorbidities, and with insulin-dependent diabetes, I would go for a bypass, even for BMIs of 38 or even 37 with insulin resistance, you know, and for, of course, BMIs above 45, I always advise patients that it's better to do a Roux-en-Y, especially with comorbidities. Above 50, hands down, whatever, even without any comorbidity, I always advise my patients, I offer them a bypass. So the relative are mostly those criteria, the BMI, the comorbidities, and sometimes very infrequently, if I see a patient or from the psychologist, I get a tip that this patient might not be compliant with medications over a long time. You know, for me, I'm with the school that gives supplements for sleeves only for 8 to 9 months with close follow-up, and for life with the Roux-en-Ys. So if I get a tip from the psychologist that this patient might not really take vitamins for years, with a relative indication or contraindication like 45 BMI with diabetes on oral hypoglycemics, I might still offer them a sleeve, because, you know, not taking supplements with a bypass would be a disaster.
Yeah, sure, sir. Sure, sir. This is what is your protocol of pre-op endoscopy?
While all patients who have history of dyspepsia will be endoscoped in my center. Those who don't, I don't. I mean, but I ask specifically. It's not about leaving it to the patient to volunteer the information. It's a fixed question in my review with the patients. Do you have dyspepsia reflux? I had it any time in the past 5-6 years. How frequent are you taking medications? So when they have it as a problem, even if not serious, even if they take antacids like twice a month, 3 times a month, I scope them. My problem is probably, I don't know what about in Dubai. My problem is securing insurance approval. It's really, really a nightmare, but we try as much as we can. But for those patients who don't have an issue of dyspepsia or reflux, I don't scope them regularly. And of course, the literature is full of data that supports each approach, but there's good evidence that preoperative endoscopy for reflux is not that much valid without symptoms. Of course, there are many other indications to do preoperative endoscopy, but that's not our topic.
Professor, you know better than me. So obesity, and also in morbid obesity, so maybe due to high pressure, intra-abdominal high pressure, so patient, yes, experience some stages of GERD. So we know better. So you know better than me. So GERD is a wide definition. So definite. So maybe I have no idea. So which percentage of your patients was suffering with these symptoms, and how and which percentage are you doing upper endoscopy? What is my question? So what was your finding in these symptomatic GERD patients? So if you compare, 50% were really reflux, or no, there was nothing in these cases?
Well, to tell you the truth, I mean, the number of it's 12 years now, almost 13 years in the same center. We don't have a problem. We do get every now and then a patient with GERD following sleeve. I would say around less than 10%, surely. But I had only one patient of mine who had reflux, and that was a patient of grade 2 esophagitis who insisted on having sleeve. He said, all right, he even actually, he was that intelligent. He even went online and printed me some data saying that you can do sleeve with GERD if it is mild. And according to him, I mean, he signed so many papers. He ended up having a revision to Roux-en-Y gastric bypass 6 months later. But that was the only serious case in 13 years. I had like less than 10% of patients who had some degree of GERD. I know any patient who developed GERD in the first visit and having still complaining of even mild dyspepsia, I keep them on proton pump inhibitors for a minimum of 2 months, and the results are fantastic.
Sir, excellent. Sir, what is your opinion regarding H. pylori eradication before surgery?
For the same thing, whenever I scope someone or somebody has GERD, we do H. pylori. and if it's positive, we'll wait until it's eradicated. Or sometimes I had a patient like 8 weeks ago with dyspepsia who had a very strange ulcer very close to the cardia. Biopsy was normal. I mean, just ulcer, there was no malignancy, and flow test was positive. So those patients with an ulcer or flow positive, if they have H. pylori, then we'll wait until it's eradicated, but we don't do it routinely for our patients, only for symptomatic patients.
Yeah, absolutely agree, sir. Because now we can also do breath test also for some cases. So are you prefer breath test or no? Only in the case that you do endoscopy, so you check.
Yeah, breath test actually is much more valid for follow-ups. It's not really of significance in the primary cases. The stool, the antigen tests are better in the primary cases. But when you diagnose a patient and put them on a H. pylori eradication scheme, yes, I do check them with the breath test 4 weeks to 5 weeks later.
Sir, when this H. pylori positive, and you also know maybe and so after 3 year, after 4 year, after 6 months, I have no idea. So maybe again patient will be positive. Have you any protocol to follow this H. pylori positive patients?
Well, to tell you the truth, you know, I mean, I don't know, the number was so meager. I mean, it's much less than 10% that I needed to do H. pylori for, or they turned out positive. So, and I didn't come across really anything in literature that warrants routine reassessment of H. pylori, especially with asymptomatic patients. So I don't do it routinely, no.
Because, sir, why I am asking this question? Because nowadays, so if any international conferences and anywhere, so they talk about GERD after a sleeve gastrectomy.
Yes.
So now when we are discussing this safe sleeve gastrectomy, because in my opinion, so sleeve is a good surgery. Yes, personally, my practice is OAGB. This is reality, but sleeve is a good surgery. So we must help sleeve gastrectomy. We must think about this. How can we decrease the chance of complication of sleeve? So what is my question regarding this? So if a patient is suffering with GERD, after a sleeve gastrectomy, we must rule out H. pylori, because H. pylori is also a factor that maybe increase the chance of GERD after sleeve gastrectomy. If patient is suffering with H. pylori and we eradicate in time, maybe patient will not face such a situation. This is just idea. So if
Agreed.
because you are a 30, definitely,
Agreed.
sir, you are a 30, and now I am talking with someone who can ask so, and who can change the protocol. You are one of the in my opinion, so someone who will guide. You are making guidelines. You are one of the person who make guideline for youngsters, for us, for all of the world. So if we start this, if patient is H. pylori before surgery and we eradicate, so there is, yes, protocol after surgery also. We must follow this patient, specific patient, not all the patients. But if patient is H. pylori positive before surgery, we follow, then maybe. And also we can see if patient, so this is data. I have no idea. I personally, I have no data, because my number of sleeve is much less. So if, because you have, so if you can also compare, if a patient with the H. pylori positive, you can follow after surgery. Again, this patient is suffering after 1 year, 2 years with GERD or not. So what was the percentage of these patients who were positive before surgery? After surgery, how was their journey, especially for GERD?
Actually, the thing is, I agree with you, but it's actually part of the management, because I scope every patient who develop symptoms after surgery. I scope them routinely. There are no exceptions here. And I take a biopsy for H. pylori, tissue biopsy. And those who have H. pylori positive will get treated. So I didn't really do a study about that. That's a very good idea. Probably we can start that, especially with the numbers that we have. But every single patient who developed dyspepsia at any time down the road following sleeve gastrectomy, whether they were positive before or not, will be endoscoped, and they will have a tissue biopsy. And if it's positive, they will get standard treatment. So it's a good idea to actually to screen, to check out of those who were positive, who develop symptoms again and were still positive and see any correlations. It's a good idea, actually.
Sir, you can also follow retrograde this study. So you can ask any your registrar or any your junior. So especially those patients who has been scoped due to GERD after a sleeve gastrectomy, because routinely you do biopsy, which percentage was H. pylori positive in these cases. Maybe if there is more than 50% were H. pylori, okay, then we must think about this.
Not really, actually. I would say something. Again, I didn't do a personal study. Probably I should. Thank you for highlighting that. But I can easily say it's less than 15%. Definitely not more. I mean, it's much more negative than positive.
Thank you, sir. What is the reason? So, if you think so, now my question regarding GERD also. So definitely, because this is the main issue after a sleeve gastrectomy, and as you have mentioned, so grade 3 and 4 definite. This is a contraindication, but you prefer grade 1 or 2. So have you experienced worseness of GERD after a sleeve gastrectomy in these cases, and which percentage?
As I told you, Dr. Amran, I mean, the vast majority. Again, I don't have percentage. I'm sorry. We do have a lack of staff who do the analyses and those things in private practice, but it's it's not a phenomenon. It's not something that we are observing. It's quite infrequent that we get a patient who is having dyspepsia. I told you only one patient in 13 years required revision, and the others, the few ones that we have, they do very well with the 2 to 3 months of proton pump inhibitors treatment. I think if you allow me to elaborate on that, you said something earlier which I'd like to touch on, and about if it's not H. pylori, what probably is the cause of GERD following sleeve if it's not H. pylori, which is not the way I see it in practice. And that issue has been actually touched before in the 5th International Consensus of Sleeve Gastrectomy. That was it was published in SWORD 2016. They agreed. The panel agreed that GERD, I mean, sleeve can be done very much safely with GERD, providing you are choosing the patient's criteria properly. And as why GERD happens after sleeve, Hempens published a very interesting article about the biphasic behavior of sleeve with GERD post-operatively. His data showed that in the first year, around 22% of patients develop GERD. And that number goes to 3% in 3 years. And it goes back to 23% in 6 years. So his explanation is quite interesting. And there are a few photographs, I mean, x-rays that support it. It's called the neofundus formation. And the two factors that, in his opinion, that I believe, I mean, I really believe in it also, that cause GERD following sleeve are, firstly, narrower than it should be in caesura. Actually, he didn't call it caesura, he said mid-tube, a narrow mid-tube and a generous GE junction sleeve. I mean, especially for beginners, for, I don't know, people who are not very much accustomed to the technique, in difficult cases, those who do BMI, very high BMIs, they will not be very attentive to the dissection level at the GE junction because of the sensitivity of the area. So they leave a bit wider than they should fundus of the body there, and narrower than it should be mid-body. So what happens in 3 years, the upper wider body will get dilated because of the narrow mid-body. Narrow mid-body will cause back pressure, and food stasis and fermentation will stay in the upper part. That's his explanation, which I agree with. It will lead to dilatation of the fundus. And if you look at his radiology, it's a neofundus. It's a relatively big fundus there. And this big fundus, compared to the narrow mid-tube, because a larger fundus will secrete more acid. And it's not an obstruction, it's a stenosing in the outlet that will increase the incidence of GERD. And the numbers he gave were very clear, the data. 22% at 1 year, 3.1% at 3 years, and 23% at 6 years. This biphasic show. So I believe in that. I believe it's not a very wide, but a relaxed mid-body, just like I showed in the technique, and not too generous GE junction stapling will give you definitely a much safer sleeve.
Sir, excellent. Also, in this debate, you explain, and also definite as you have explained. So, in both era, both timing, etiology of GERD was different. In earlier stages, that was different, and definite different patients. If we see, so we cannot ask the same patient who were suffering with GERD at earlier stages were also suffered after 6 years. No, because etiology is different. If there is more fundus, so definitely maybe in earlier stages there was nothing for them, but after 5 years, 6 years, more dilatation. And this is a great message for our youngsters. So if they follow proper tips and tricks and proper technique, then there is less chance of facing such issues. So much thanks, sir. Sir, what is your opinion about hiatal hernia?
Well, hiatal hernia now, there is more or less a general agreement that there are no contraindications to doing sleeves with hiatal hernias, and you can always repair hiatal hernias. But again, with the school of, I think the majority of surgeons don't really interfere with small hernias. Hernias less than 3 centimeters that are causing no symptoms are better left alone. But I always, when there is a suspicion of a weak crus but no hernia, I always stitch the upper part of the sleeve to the left crus.
Oh, excellent. Sir, are you prefer to do chloroplasty or repair it if hernia, this hiatal hernia is 4 or 5 centimeter?
Yes, if it's more than 4, I do chiro repair. Yes. The thing is, Dr. Amran, it's really perplexing. You know, anatomically speaking, and literature-wise and training-wise, what really matters in the repair is the fundal wrap rather than the crural repair. Crural repair is important, but it wouldn't really prevent sliding of the tube up to the chest. It wouldn't. It helps probably to improve reflux. I don't know, probably, but I'm not really confident that it will prevent a sliding hernia. But I do it only because the literature says so. And even when I do it, I always fix the upper end of the sleeve with it to the left crus.
Well, sir, as you have mentioned, so this gastropexy with the left crus, are you satisfied and happy with this?
Yeah, actually, I've done like, I don't know, 20. I mean, it's not a big number because they are either hernias and you repair them, or they are not and you don't. So in those suspicious areas where patients 20, 25, no more. I mean, the contrast post-op was always great and the patient never complained.
Sir, what is your opinion regarding omentopexy or fixing this gastric tube with the anterior fascia of pancreas?
When I do it, I don't fix it to the anterior fascia of pancreas. When I do it, actually, in selected cases where there's an inadvertent twist, a twist that, I mean, by the vast majority of my cases, just like you, so they are straight and they're fine. But once in a while, every year, every several months, you get as a staple line that you're not very happy with. You feel it looks like if it's twisted, and when you do the leak test, the shape of the banana is not very assuring. So I suture the greater omentum back to the staple line with continuous suturing. And a tip here, I mean, at least the way it happened to me, because I had to go back for a patient again and do it again. I said, all right, why would you do it through the entire length? Do it only in the places, a couple of places where the twist you think is there. It fails because when the patient is lying down and you put those stitches lying down, it looks beautiful. But don't forget, this is a very thick a very fatty omentum, and that patient will stand up. And when they stand up, the weight will be drawn only to the knots, the two knots, and it will cause a stenosis or a stricture. So when you want good results of the omentopexy, the way I see it is you have to do it through the entire stomach, which I do on those very infrequent instances when I suspect a twist. I take the omentum and I suture it with continuously from the beginning of the staple line till the end.
Sir, excellent. Sir, regarding this stapler line and forcing, so there are different techniques, different material. Are you preferring selected patients?
I tell you what, it's a big thing. Actually, I have presented some review of literature about it in Arab Health and in IFSO. And I've shown with evidence, probably you can share, I can share it with the anytime if you like. I have proven with evidence everywhere that there's actually the only difference, the only real difference that you can add is with buttressing material. Otherwise, you can, of course, suture, and the suturing to be effective, it has to be with invagination, not through and through, because even leaks has happened with through and through enforcement. It reduces bleeding or stops bleeding definitely, but might cause a leak, but not like with invagination. But the problem with invagination is that you will cause a more stenosed sleeve with invagination. So one of the criteria you mentioned also a short while ago, something about standardization of the technique, which is really important, reproducibility. So if you do invagination, you can't really have a reproducible technique the same size of the tube every time, because you can't really make this take the same bite every time. So the data shows that not doing anything, just like I showed in the video, or suturing, doesn't make a big difference. What makes a big difference is adding buttressing material. And if it was for me, cost is not part of it. I would have used it always, but the cost is an issue.
Yeah, thank you, sir. I know. So because I'm also in a private practice, and following a patient and collecting data is really a challenge. But overall, we know our patients. Definitely, we follow our patients. So about which percentage of, because now you are following more than 1 decade of sleeve gastrectomy cases, which percentage of your patient are suffering with weight regain?
I can tell you actually actual numbers, because I mean, of course, probably some patients didn't come back to me. They went somewhere else. I don't know. But the number of patients, my own patients that I had to reoperate on for weight regain over the past 13 years till now are 11.
It's good.
Yeah,
it's good. So, sir, what is your opinion regarding re-sleeve in such a case?
Well, re-sleeve probably is mentioned now only as an example of what not to do for weight regain in sleeve gastrectomy. I mean, yes, I've done once one re-sleeve 2 months ago, and the one before it was like 6 years ago or 5 years ago, because in this patient, I mean, I don't know who did the sleeve, but if you look at the X-ray, Dr. Amran, you would not believe that a sleeve was done, because it was all 80% of the stomach. Yeah. And that probably is the only indication where re-sleeve can be practiced now. There's a lot of data that shows that it's not really effective unless there is a huge stomach left over.
Sir, in your experience, so this is a little tricky question. So which patient is difficult for a sleeve?
Short stature and high BMI.
Oh, so this is good question. This is also.
You mean about technically difficult, right?
Yeah, technical difficult.
Yes, it's a short male with high BMI. I operated on a patient who had a BMI of 68, and he was 158 centimeters tall, and he refused bypass first, and then secondly, I thought probably for him he had sleep apnea, hyperlipidemia. I thought probably to do a sleeve to downstage him and do something else later, and that was one of the most difficult sleeves I have ever done. Sir,
because this is a great question. Because another question regarding morbid obese like BMI, high BMI, and yes, tummy is pendulum. So this you can see a huge tummy is there till knees of the patient, And so how you insufflate in such a case? Have you any experience?
Well, insufflation is not an issue. Insufflation is always at Palmer's point. I mean, something close to that. For me, I mean, internationally, it's open. And now nobody does various needle widely, but I do it still routinely. Call me old-fashioned. I'm very happy with it. I had only one issue, to be honest. I had one issue of a superior mesenteric vein puncture over the past 13 years, but it has so many mitigating circumstances. So in those difficult cases, Imran, I think the best way to go is for open insertion of the first trocar. That's the best way.
This is so because we have many viewers who are youngsters, and in my, as you have mentioned, so if such a case like so short stature, high BMI, male case, they must refer to someone who is doing,
Exactly.
who is expert
Exactly.
in tertiary
Exactly.
hospital, don't experience in a hospital, then there will be issue and he has no help. So this is a great question, great message, sir. Sir, regarding, so also you have mentioned regarding GAID, and we have talked a lot about, and also you have mentioned, so regarding PPI, you offer your patients for 3 months. Yes.
I'm sorry, I offer it to patients who are symptomatic. I mean, but not, they don't warrant an endoscopy. They are not severe symptoms. Yes, I'm very open-minded with that. And of course, but we're not talking about it today. I give it to all my OAGB patients for 2 to 3 months, even without symptoms, post-op.
Yeah, this was same my question. So in asymptomatic patient, also in a sleeve gastrectomy, you offer 3 months?
No, no,
So how
never.
much you offer these cases of sleeve gastrectomy? They have no
2 weeks.
symptoms.
2 weeks.
Only 2 weeks.
2 weeks post-op, and that's it.
Okay, sir. Sir, what is your, so this is little also political question, because maybe I have no idea what will be your answer regarding endoscopic sleeve gastrectomy or endoscopic sleeve, this gastroplasty. We can.
That's a very embarrassing question, Imran. I mean, I really hope that I wouldn't be asked about it. But then there are two things, the way I feel about it and what the data says. So the way I feel about it as, what do you call it, old school surgeon or whatever you call it, you know, there's a big saying that says, non-medical, those who don't remember the mistakes of the past are condemned to repeat it. So we have done, what do you call it? We have done it in a more efficient way with laparoscopic plication, and even the fundus which is a major player in obesity, was plicated with the laparoscopic plication, and it became a hit for a couple of years, and suddenly it faded away, and nobody practically is doing laparoscopic plication now because of what everybody knows. The limited effects regarding obesity, the really troublesome side effects when they happen, and so everybody abandoned plication. Endoscopic sleeve gastroplasty is plication, but it's from within, not from without. And I mean, I respect all the people who are doing it. They are great colleagues and great mentors, and they are doing a great job for a lot of patients. My impression is that it's not, till now, there is no evidence that it's going to be the routine procedure for obesity. And the latest publication about the outcome was published in SWORD in February this year. Singh et al. They reviewed and meta-analyzed 8 big series, the total of, I think, 1,890 patients, almost 2,000 patients. And they assessed excess weight loss and percentage and total weight loss at 6 months, 1 year, and 2 years. And the best results they got at 2 years of excess weight loss is 20%.
No.
So it's not something that you consider as a successful rate for a primary first-line bariatric procedures. On the other hand, I believe it's a good procedure for a selected group of patients. Downstaging a patient whose BMI is 34, 33, and they don't want to do sleeves, they have mild diabetes. So, I mean, there is no clear cut criteria for selection right now. Even internationally, there are suggestions. But I think until we get more experience, more data, I think what will happen, this is my own impression, to endoscopic sleeve gastroplasty, it's not like glycation. It will not be extinct. It will be more refined and more limited to a well-defined group of patients where it will be very successful in the outcome. But I don't see it becoming the first-line bariatric procedure.
Sir, excellent, really excellent. And this is reality. This interview was real practical, and you have shared your experience, especially your video. In that video, hopefully, definitely you will see. So this will be till in 24 or thousands of viewers. So will be viewers, and definitely it will be very fruitful for our youngsters. Sir, any message for our youngsters who are just now going to start, or newcomers in bariatric surgery, especially for sleeve gastrectomy?
Well, thanks a lot. I think you mentioned a couple of them. I think the most important thing is getting proper training, because unfortunately I've seen quite a few results of quite a few surgeons who, see an operation here, go online, watch a couple of videos, and sleeve is an easy procedure. As a matter of fact, sleeve is not an easy procedure. It's a simple procedure, but it's not an easy procedure. There are so many things that can go wrong, and yourself and everybody in the audience have seen disasters coming from what was called to be an easy procedure. It's not. So proper training, proper mentoring, proper guidance, and once they get the proper training, when they go to start, and you just mentioned that short while ago, start with selected patients until your experience builds up and your learning curve. I mean, they used to say that there is no learning curve with sleeve. I mean, they say that after the first 50 bypasses, you become, a good surgeon. After 100, you become you become as good as you can be. And there's nothing like that for sleeve. I don't agree with that. Even with sleeve, there's a learning curve. It's not like a bypass, but still there's a learning curve. So for a youngster, besides proper training, choosing of patients in the first 50, 80 cases, and of course, selection, just like also mentioned, selecting the proper, don't give sleeve for patients where sleeve is known to fail in the future.
Sir, really so much thanks for your time, and I feel honored. This is reality. I feel honored. So you accept our invitation, and for your this commitment and great message for our youngsters, and especially personally, really I have learned a lot. So we will continue our series of this interview series of safe sleeve gastrectomy. And thanks our viewers that are till now, because I can see here from India, from Egypt, from Iraq, from different countries, they are live with us till this time, and also some colleagues I see from Europe. So much thanks, and this all this system and also this series we can continue with your support, and because we need your comments. If you have any question, you can ask your question. So in comments, and also professor will be available and will answer your question. So we will continue this series of safe sleeve gastrectomy, and next week, next Tuesday at 10 p.m. Dubai time, we will be with another legend of bariatric surgery. Sir, again, so much thanks, and have a nice time, and we need your support and guidance.
Thank you very much, Dr. Amran. Thanks a lot for this great opportunity. Thanks for your effort at pushing the CME online to this level, and thanks to the audience for their time and joining us.
Sir, so much thanks, sir, and have a nice time, sir.
Good night.
Thank you, sir. Good night.
Bye.